Hello dear respected students, today we are continuing our series of our therapy lectures and we will focus on percussion of organs of a healthy patient. Percussion, from Latin translated as a hitting. Percussion is a method for examining a patient which consists in tapping on the surface of patient's body in order to judge the physical properties of the organs by the nature of the sound obtained at the same time. There are two types of percussion, direct and indirect. Direct percussion mostly we use to percussion of bones, for example, skull. Direct percussion has some drawbacks like painful for the patient. Most of energy is spent on pressing soft tissues. The sound is quiet and unclear, whereas indirect percussion permits soft tissues are pressed down with the placimeter. Placimeter limits the spread of impact to the sides and also give us very clear sound which is originated in different organs. And indirect percussion we use more often than direct percussion. During percussion we always should keep the rules. Room should be warm. Usually placimeter is the middle finger of the left hand. Percussion strikes are applied with the pulp of terminal phalanx of the middle finger of the right hand. We call it as a hammer along the middle phalanx. The nail of striking finger should be cut short, hand should be warm, the finger placimeter is tightly applied to the body with the palmar surface. The axis of terminal phalanx of the hammer finger should be strictly perpendicular to the surface of the placimeter finger. Percussion strike is carried out due to movement in the wrist joint, not in elbow joint. Wrist joint. Percussion strike should be short and must be elastic. Different kinds of organs give us different sounds. For example, if you percuss the lung region, it gives us resonant sound. If you percut muscles and bones, it will be flat sound. Cardiac dullness, all thick organs like heart, liver, spleen give us dull sound. Also, we have tympani sound, which can be detected in abdominal region, on the stomach. Let's start from percussion of chest. To percussion of chest, we should know about main topographical lines on the chest. And first line, this line which divided our sternum into two parts. This is anterior medial line, and line which goes through the border of sternum. This is sternal line. Then you should find out mid-clavicular line, which divided clavicles into two parts, right and left mid-clavicular lines, and line which is located between the sternal and mid-clavicular line. We call it as a peristernal line. Also, you should know three axillary lines, anterior, middle, and posterior axillary line. Also, in posterior part of chest, you see first is posterior middle line, and then vertebral line. Next is a line which goes through the scapular angle. This is scapular line, and line between the scapular line and vertebral line we call it as a paravertebral lines. Also, to percut the lungs, also after percussion you should auscultate lungs. You should know two parts of lungs and also lobes, lung lobes. You know from anatomy class that right lung has three lobes and left lung two lobes. To detect the real localization, you should find out T3 and a line which is divided T3 with the interior 6 rib. This line divided this line which connected with the T3 and 6 rib divided into two main lobes, upper and lower lobes. And to detect the middle lobe of right lung, you could use a slope of fourth rib, and this is slope of fourth rib, which is which is crossed by the mid-axillary line, formate the second lobe of right lung. For detect the upper and lower border of left side, you should find out T3 and connect T3 with the anterior sixth rib. There are two types of percussion of lungs: comparative and topographic percussion. Comparative percussion we use to compare the resonant sounds which originate in both sides of lungs. For comparative percussion, use the light percussion, percuss the interior chest wall, comparing symmetrical points from supraclavicular areas to third intercostal space along mid-clavicular lines, while till only third intercostal space from left side, because in fourth and fifth intercostal spaces localized heart dullness. And for percussion, it's necessary to use only intercostal spaces, and also you should know always you should start from the supraclavicular fossas, and also you should know that intercostal space which are localized just under the clavicles we call it as a first intercostal space. After comparing on the interior part, you should go to the compare lateral part, space by space, and then posterior part. You use mid-axillary line on the right side from resistance, and then go to the left side till on the right side till liver dullness, on the left side till spleen dullness. And then in symmetrical area you go to the percussing left side or posterior part, and you see direction of plesimeter. First is in horizontal position, then doctor change position of his fingers to the vertical position and compare interscapular spaces, and then go again change into the horizontal position until liver and muzzle dullnesses. Again, here is anterior part and lateral part and posterior part comparative percussion. Next is topographic percussion of lungs. Topographic percussion we use to detect the upper and lower borders of lungs. And upper border, there are two upper borders in front of patient. This is anterior upper border, and then behind the patient is posterior upper border of lungs. Anterior upper border of lungs normally located from 3 to 4 centimeters higher than clavicle. For determination, you should find out middle of clavicles, and you should put plesimeter above the clavicles on the center, and percut strike centimeter by centimeter to the direction of sternocleidomastoideus muzzle from resonant sound till dull sound, and always mark on the side of resonant sound, and this will be from 3 to 4 centimeter. And then you go to the posterior part. For detect the posterior upper border of lungs, you should find center of spine of scapule. From center of spine of scapule, centimeter by centimeter from resonant sound till dull sound, doctor percut to the direction of 7th cervical spinous process, and upper posterior border of lungs localized at the level of the 7th cervical spinous process. Then you should find out width of apex of lungs. its name is Chronix isthmus. Chronix isthmus percusses across the top of each shoulder to identify the approximately about 5 to 6 centimeter band of resonant overlying each lung apex. To detect the Chronix isthmus or width of apex of lungs, doctor should put his finger on the trapezoid muscle and percut from resonant sound till dull sound at the beginning to the medially and then laterally. Always mark on the side of resonant sound, and this distance should be from average distance 5 to 6 centimeter, but may correlate from 3 to 8 centimeters. And then you go to detect the lower border of each lungs, and lower border you should percut by whole line, which we already knew. Left side lower border of right lung always started from percutting peristernal line space by space, localized on fifth intercostal space, and then go to the detect by mid-clavicular line, localized on sixth rib, anterior axillary line, mid-axillary line, posterior scapular lines, vertebral lines, and lower border of left lung. We should start percussion from anterior axillary line because in peristernal mid-clavicular line localized heart dullness. And here is exact lower borders of right and left lungs in normostomic patient. After getting lower borders, you can check diaphragmatic excursion or diaphragmatic movement. May be measured by noting the distance between the level of dullness on full expiration and full inspiration, or deep expiration and deep inspiratory phase. For this, first you should get a normal condition of patient lower border of lungs, then ask patient to inspirate to expirate, and then fully expirate and go to the upper direction from resonant sound from dull sound till resonant sound, and then make mark here on the side of dull sound. Then you ask patient to full inspirate and go down during inspiration centimeter by centimeter, and mark on the side of resonant sound. This distance between the full expiration and inspiratory phase will be diaphragmatic excursion. Normally, the largest diaphragmatic excursion present in axillary lines, for example, mid-axillary, anterior axillary, posterior axillary lines, and totally it equal to 6 to 8 centimeters. By other lines, it's 4 to 6 centimeters. Next is percussion of heart. Task of percussion of heart is the identification, the dilation of ventricles and atriums, and revealing the expansion of vascular bundle. To detect the borders of left and to detect the borders of heart and borders of bundle of vessels, we use two borders. First is relative dullness and absolute dullness of lungs. Hearts. Heart, a relative and absolute dullness of heart. Right border of the heart is formed by the right atrium, 0.5 till 1 centimeter lateral to the right sternal lining, 4 inches space. Left border of the heart is formed by the left ventricle, 1.5 centimeters medial to the mid-clavicular line in the 5th interspace, and left atrial appendage makes up the upper border, which localized on 3rd rib. To determine the borders of heart, first we need detection of the standing level of the diaphragm. From you go by mid-clavicular line, space by space down, you are striking, and till dull sound, from resonant till dull sound. And as you see here, always we should mark on the side of resonant sound. And then you should detect the right border of relative dullness of heart. There are two dullnesses, relative dullness and absolute dullness. What is relative dullness? This is real size of heart. Relative dullness is heart, all heart region, including region which is covered by lungs. Absolute dullness of lungs, which region of area of heart which is free from free from the lung. Right border of heart detected by fourth intercostal space. After getting diaphragmatic dullness, you go to the one space above to the fourth intercostal space, and you go vertically space vertically centimeter by centimeter per cut to the direction of sternum, and on the level of border of sternum by fourth intercostal space or 1 centimeter outside from sternum this is normal right border of heart. Next, upper border of relative dullness of heart, we percut by left peristernal line, space by space, and normally localized on the on the third rib. And always you should see here, always we should mark on the side of resonant sound. Next detection of left border. To detect the left border, first please you should remember how palpate the apex beat. First you should find out apex beat. Normally apex beat localized on the fifth intercostal space 1 to 1.5 centimeters inside from left mid-clavicular line. First you should detect the apex beat, and from anterior axillary line by fifth intercostal space you should percut centimeter by centimeter from resonant sound till dull sound, and always you should mark on the side of resonant sound. Next is measuring of diameter of heart. Diameter or normal diameter of heart is 11 to 13 centimeters. For measuring of this diameter, you should first from right side fourth intercostal space till anterior middle line you should measure, and then from left side by fifth intercostal space you also measure till anterior middle line, and total it should be total width of heart should be 11 to 13 centimeters. In case of enlargement of right side or left side, that will be increase this size. In case of myocarditis or congestive heart failure, of course, in case of valvular heart disorders, of course, increase heart size and become to be more than 13 centimeters, sometimes even 20 or 25 centimeters. Next is vascular bundle. Borders of the vascular bundle coincide with the right and left edge of the sternum, determined by a second intercostal space, and width does not exceed 5 to 6 centimeters. And to detect this, you should go from the mid-clavicular line by second intercostal space centimeter by centimeter from resonant sound till dull sound, and always marked on the side of resonant sound. And what does it mean, vascular bundle? Vascular bundle includes three types of vessels. First, three vessels. First is aorta, second is pulmonary artery, and third is vena cava superior. Next is a determination of configuration of the heart. Normally, an obtuse angle west of the heart is determined along the left contour of the heart between the vascular bundle and the left ventricles, and you can detect that by whole intercostal spaces, find out whole configuration of heart. And you see here contours of relative dullness. This is real size of heart, and contours of absolute dullness. This is part of heart which is free from lungs. And there are two types of configuration of heart: mitral configuration and aortic configuration. Our heart can change this configuration because of mitral valve stenosis or mitral insufficiency or regurgitation, and because of increasing, enlarging left atriums. This is a configuration of heart change into the mitral configuration. Aortic configuration of heart occurs in aortic stenosis or in aortic regurgitation, and you see because of enlarging of left side, we detect as a aortic configuration of heart. And absolute dullness of heart, normally absolute dullness of heart, we should for this use very low pitch striking, and we detect the right side along the left sternal edge of 4 to 6 rib, upper lower edge of the 4 rib along the left peristernal line, and left fifth intercostal space 0.5 centimeters medially of the left border of the relative cardiac dullness. You see 1 centimeter or 0.5 centimeters inside the left relative cardiac dullness. Right side you see on the left border of sternum, and upper this 1 rib down to the down from the relative cardiac dullness. Percussion of liver. There are two types of percussion, two methods. First is Obraztsov techniques, and next is Kurlov techniques. Obraztsov techniques, for this percussion we use for detect the upper borders, we use right peristernal line, mid-clavicular line, and right anterior axillary lines. Right peristernal line 5th costal interspace, right mid-clavicular line 6th rib, right anterior axillary line 7th rib. And you also see lower border of lungs. This is lower or upper border of liver, and lower border of liver dullness by Obraztsov techniques will detect by right anterior axillary line, mid-clavicular line, peristernal line, mid-sternal line, and oblique line. You see oblique line. And there are liver's dullness sizes: anterior axillary lines 10 to 12 centimeters, right mid-clavicular line 9 to 11 centimeters, and peristernal line 8 to 11 centimeters. But mostly in our practice we use Kurlov's techniques, and Kurlov techniques, there are only 3 sizes by mid-clavicular line, right mid-clavicular line. This size should be 9 plus minus 1 centimeter, and then we detect by mid-sternal line 8 to 1 centimeter, 8 plus minus 1 centimeter, and oblique line is 7 plus minus 1 centimeter. Again, which we detect in our patient, C by midclavicular line 9 plus minus 1 centimeter, by anterior middle line and oblique line. Percussion of spleen. Also, we use a Brestov techniques. Identify the small oval area of splenic dullness near width of 4 to 6 centimeter and length 6 to 8 centimeter. Our spleen located in area between the 9th and 11th ribs in anterior border does not cross the left costa articular line, and you see length of our spleen located on the slope of 10th rib. And to detect, of course, you should first detect the by mid-axillary line from resonant sound till dullness, and from tympany sound, from abdominal region, from tympany sound till dullness, and this will be width of spleen, normally from 4 to 6 centimeters. And then by direction of 10th rib, you should start your percussion from scapular line. From scapular line, by the slope of 10th rib you percut from resonant sound till dull sound, and always you should mark on the side of resonant sound. Then you should go from umbilical zone, from tympany sound till dull sound, and always you should also always mark on the side of in this region on the side of tympany sound, and will be length of our spleen, which is from 6 to 8 centimeters. And normally, spleen is not palpable, but you can percut and get lower and upper borders of spleen. Kidney. For kidney percussion, we use not striking. We use not exactly percussion. We can hit by our hand and we can detect the tender costophrenic angle. It may occur in pyelonephritis, in abscesses, in infarction, or in any stone formation, and we can use direct striking or direct percussion, and use ulnar surface of percussion. Also, percussion technique we use to detect the ascites. Ascites is accumulation of fluid in abdominal cavity. It may be detectable if fluid is more than 500 milliliters. During observation, you can find out full flanks like frogs. It may occur because of obesity or because of ascites. Very important to detect the level of fluid if accumulated. For example, fluid can accumulate in abdominal region due to liver cirrhosis, or maybe due to congestive heart failure, and during percussion, it may be detected as a fluid wave or thrills. And also this percussion we use to detect the level of fluid, first in when patient is laying down horizontal position, and backside you can detect the lower border of dullness, and upper border give us tympany sound. And if fluid accumulated, of course, when patient lies in backside, this is fluid move, and also you can find out this is transition point, which above will be tympany sound, and in down will be dullness sound. Okay, and I finished my lecture. Thank you for your attention, my dears.